So again, good morning, everyone, and welcome to the Orlando GI Journal Club for June 2023. We're going to do something a little bit different. Today, we're going to be presenting one really interesting study out of the Dutch Pancreatic Cancer Group in the Netherlands. And then I'll be also presenting some of the best abstracts from DDW this year. So the first study is by Clatter et al. It was published in Gastroenterology this month, and it's looking at surveillance for pancreatic cancer in high-risk individuals, and it was a propensity score matched analysis. Population-wide pancreatic cancer screening programs are presently not viable due to the relatively low incidence of pancreatic adenocarcinoma and absence of reliable screening tests applicable to mass screening. Carriers of germline pathogenic variants in pancreatic cancer susceptibility genes or individuals with strong family history are eligible for participation in pancreatic surveillance programs. And the lifetime risk estimates for pancreatic adenocarcinoma in these high-risk individuals can range from 2% for BRCA1 to greater than 30% for Peutz-Jeghers syndrome. Recent studies of individuals at high risk for pancreatic cancer showed a benefit from participation in surveillance programs. So the aim of this study was to evaluate the extent to which pancreatic cancer surveillance resulted in stage shift, resectability, and survival in pancreatic adenocarcinoma in high-risk cohort of germline CDKN2A-P16 pathogenic variant carriers compared with patients diagnosed outside of a surveillance program. These authors took patients who were part of a surveillance program, and pancreatic surveillance program exists currently in the Netherlands for carriers of proven pathogenic or likely pathogenic CDKN2A-P16 pathogenic variant. And in this academic center, these patients were offered from the age of 45 or 10 years before the youngest age of familial onset, and surveillance was performed using MRI or EUS every 6 months. Patients were diagnosed with pancreatic cancer from 2000 to 2020, were also identified from the Netherlands Cancer Registry, and so these provided the patient cohort with pancreatic cancer that was outside of the surveillance program. These authors then performed a propensity score matching analysis, and they matched in a 1:5 ratio patients from the general population with primary PDAC are diagnosed outside of the surveillance with carriers of germline CDKN2A/P16 mutation diagnosed with pancreatic cancer during the surveillance program. They then compared the resectability, stage, and survival between the patients diagnosed with pancreatic cancer under these two different circumstances, surveillance versus no surveillance program. So these were the results. When they looked at all the patients, they were able to identify 31 patients with pancreatic cancer with the pathogenic variant who were part of the surveillance program, and they identified over 43,000 patients with pancreatic cancer from the National Pancreatic Cancer Registry in the Netherlands. Then they matched patients diagnosed with cancer in the surveillance program, the 31 patients, in a 1:5 ratio, with pancreatic cancer patients who are not part of a surveillance program from the Cancer Registry. And when they matched a 1:5 ratio, you end up with 155 patients in the non-surveillance group, and they were matched according to age, characteristics of the patient, etc. And what they then did was just look at the baseline characteristics. And as you can see, the most common age of diagnosis was over the age of 50 here. And the year of diagnosis that they also looked at, actually the most number of patients were diagnosed from 2016 onwards. The most common site for tumor were head and then body and tail. Head with body and tail, and surgical resection was performed in 71% of the patients in the surveillance group compared to 18.7% in the non-surveillance group. So when they looked at the cancer stage, this is what they noticed. If you look at the surveillance group here, 39% of patients are stage 1, followed by 36% in stage 2, 16% in stage 3, and 10% stage 4. When you look at the non-surveillance group, the majority of patients were in the stage 4 group, 61%, and actually the frequency is reverse of the surveillance group, followed by the most number of patients in stage 3, then 14% stage 2, and then 6% in stage 1. And this difference was statistically significant. Also, the surgical resection was performed in a greater number of patients in the surveillance group, 71% versus only 19% in the non-surveillance group. And this was translated odds ratio of 10.6. When looking at survival, when looking at hazard ratios, so the likelihood of surviving at 5 years, the survival for non-surveillance group was 4.3%, and survival was at 5 years is 32.4% in the surveillance group. And this translated to a hazard ratio of 0.31 in the surveillance group compared to the non-surveillance group. So the limitation of this study is that there are a small number of patients in the surveillance group, only 31, and therefore when you're performing propensity match scoring analysis, the whole number of patients ends up being fairly small, only 155 in the other group because they're matched. There is also potential for bias from unmeasured confounding factors. And the third limitation is that there is comparison of highly selected group of individuals with a germline CDKN2A/P16 pathogenic variant in the study with individuals from general population of whom the potential presence of germline mutation was not known. So the main take-home point is that surveillance of pancreatic cancer in high-risk individuals did result in significantly earlier detection, increased resectability, and improved survival compared with average risk individuals diagnosed with pancreatic cancer who are not under surveillance. And this reaffirms that pancreatic cancer surveillance for certain high-risk individuals is beneficial and could have a meaningful impact on disease course. We're going to continue our journal club with some of the most interesting and impactful abstracts from DDW this year, which was only a month ago. Our first study is looking at the lack of effect of endoluminal RFA on survival and stent patency in patients with cholangiocarcinoma and pancreatic cancer. This was a randomized trial by Jarosova et al. Endoluminal radiofrequency ablation has been suggested as a promising treatment modality for palliative treatment of cholangiocarcinoma and pancreatic cancer. In the randomized trial, endoluminal RFA with stenting versus stenting alone was compared as treatment in patients with malignant hilar obstruction with survival as the primary outcome and stent patency as the secondary outcome. These authors enrolled 161 patients with malignant biliary obstruction, and they were randomized to either RFA with stent or stent alone. The recruitment was terminated for futility. However, after interim analysis, because there was no significant difference in survival in patients with cholangiocarcinoma and pancreatic cancer between the two groups, furthermore, there was no benefit in stent patency in the two groups in both cholangiocarcinoma and pancreatic cancer. There was no difference in adverse events also between the two groups. Therefore, in malignant biliary obstruction, endoluminal radiofrequency ablation, in addition to stenting, was not superior to stenting alone in prolonging survival or stent patency. Our next study is looking at ESD and IBD patients for visible dysplasia. This was a retrospective multi-center study from France. The main aim was to assess the short and long-term efficacy of ESD for visible dysplasia in IBD patients. So these authors performed a retrospective multi-center study, including consecutive ESD patients with IBD who had dysplasia. The outcome was R0 resection. 89 lesions in 83 patients were included. 20 of these patients had Crohn's disease. The mean follow-up was 26 months in this study. The median IBD duration in these patients was 21 years. 50% of UC patients were E3. Among Crohn's patients, 68.4% were L2 and 26.3% were L3. En-bloc resection or zero resection and curative resection were achieved in 91, 80, and 77.5% of the lesions, respectively. And 1 patient required surgery for complications, 3 required surgery for ESD failure, and 6 for poor prognostic histological features. Traction was used in 53 cases, providing higher en-bloc resection rates for larger and severely fibrotic lesions, and high-volume centers who performed more than 100 colorectal ESDs per year performed larger and faster resections with less recurrence rate. Recurrence was more frequent in Crohn's than UC patients. So in conclusion, these authors found that en-bloc and L0 resection in IBD dysplasia is close to those able to be obtained from ESD for sporadic neoplasms. Perforation was higher, confirming that more complex lesions should be reserved for high-volume centers. Next is a randomized trial from our group looking at direct endoscopic versus step-up transluminal intervention in necrotizing pancreatitis. We performed a randomized trial to compare the outcomes between direct endoscopic necrosectomy at index session versus step-up approach for patients with infected necrotizing pancreatitis. So we performed a multi-center randomized trial of 70 patients with confirmed or suspected infected necrotizing pancreatitis over a 3-year period. Patients were randomly assigned to receive either endoscopic necrosectomy at index treatment after placement of lumen middle stent, with a step-up approach where the lumen middle stents were placed, followed by a necrosectomy at a different session if there was no clinical improvement. The primary endpoint was the number of interventions performed to achieve treatment success, which was defined as symptom relief in conjunction with disease resolution on CT at 6 months. The mean number of interventions required was significantly lower in patients who received necrosectomy index session compared to those in the step-up approach group. And while the overall length of stay was significantly shorter in the direct necrosectomy group at 9 versus 19 days, there was no significant difference in treatment success, mortality, adverse events, and mean number of readmissions between necrosectomy at index session and the step-up treatment groups, respectively. So in conclusion, direct endoscopic necrosectomy and index session compared with the step-up approach significantly reduced the number of reinterventions to achieve treatment success and also decrease the length of hospitalization. Our next study looks at surveillance for presumed branch duct IPMN of the pancreas, looking at stability, size, and age to identify targets for discontinuing surveillance. So the authors wanted to identify patients where risk of cancer was equivalent to age-matched population, thereby justifying discontinuation of surveillance. This was an international study involving presumed branch duct IPMN without worrisome features or high-risk stigmata at diagnosis who underwent surveillance. Clusters of individuals at risk for cancer development were defined according to cyst size and stability for at least 5 years. And age-matched controls were used for comparison using standardized incidence ratios for pancreatic cancer. Of 3,844 patients with presumed branch duct IPMN, 22% developed a worrisome feature or high-risk stigmata after median surveillance of 53 months, and 4.3% underwent surgery. Of the overall cohort, 42% remained stable without developing worrisome features or high-risk stigmata for at least 5 years. In patients who are at least 75 years old, the standard incidence ratio was 2.2, and in patients who are at least 65 years old with stable lesions who had lesions that were less than 15 millimeters in size, after 5 years, the standard incidence ratio was 1.77. Therefore, these authors concluded that surveillance discontinuation could be justified after 5 years of stability in patients older than 75 years who had cyst size of less than 3 centimeters, and in patients who are 65 years or older who have cysts who are which are less than 15 millimeters. Our next study looks at the evaluation of AI-enabled computer-aided detection assistance in detecting colon polyps in the community. This was a multi-center randomized trial by Ray et al. The aim of the study was to evaluate the use of computer-aided detection CAD in colonoscopy in community-based non-academic practices. Patients in 4 private practice endoscopy centers were randomized to undergo colonoscopy with or without CAD-E. The primary outcomes were adenomas per colonoscopy and adenoma per extraction, which is the percentage of polyps removed that are adenomas. 769 patients were enrolled in the study. There was no significant difference in the adenoma per colonoscopy between CAD-E and non-CAD-E groups, and 0.73 versus 0.67 with p-value of 0.496. The adenoma detection rate was 35.9 versus 37.2%. And serrated polyp detection rate was 6.5 to 6 versus 6.3%, which again were no significantly different between CAD-E and non-CAD-E groups. However, the mean withdrawal time was longer in the CAD-E group compared to the non-CAD-E group. Therefore, in this prospective multi-center randomized trial in non-academic centers, use of CAD-E did not result in a statistically significant difference in the number of adenomas detected. Next is by De Rijk et al. This is looking at development of pancreatic diseases during long-term follow-up of patients with acute pancreatitis. And this was in a prospective nationwide multi-center cohort. The aim of this study was to gain insight into the natural cause and factors associated with the progression to other pancreatic diseases following an index episode of acute pancreatitis. These authors looked at a nationwide prospective unselected cohort of patients with acute pancreatitis from 17 Dutch hospitals over a range of 7 years. Clinical data were retrieved from medical records and standardized follow-up questionnaires were sent. All patients were still alive. Primary endpoints were recurrent pancreatitis rate, incidence of chronic pancreatitis, and pancreatic cancer. 1,184 patients with a 9-year follow-up were included. Recurrent pancreatitis occurred in 25% of these patients, chronic pancreatitis in 6%, and 1% developed pancreatic cancer at a median follow-up of 24 months after acute pancreatitis. The cumulative risk for recurrent acute pancreatitis was highest for alcoholic pancreatitis, which occurred in 40% of this patient population. Male sex alcoholic and idiopathic pancreatitis, smoking, pancreatic interventions, and recurrent pancreatitis were independently associated with progression to chronic pancreatitis. Therefore, 1 in 4 patients with acute pancreatitis will develop a recurrent acute pancreatitis, chronic pancreatitis, or pancreatic cancer after the index episode of acute pancreatitis. And I think this is a very important study because this does show that when patients develop an index episode of pancreatitis, good follow-up is very important. Next is a meta-analysis of dye-sparing chromoendoscopy compared with high-definition white light endoscopy in IBD for colorectal cancer screening. This was by Haider et al. These authors aim to evaluate the efficacy of high-definition white light endoscopy versus a dye-sparing chromoendoscopy in detecting dysplasia. A systematic review of literature from 2018 to 2022 was performed, and the primary outcome was the proportion of patients identified with dysplasia. Secondary outcome measures were proportion of patients with high-grade dysplasia as well as colonoscopy duration. The authors performed separate meta-analysis of randomized trials and non-randomized trials. In randomized trials comparing direct white light and dye-sparing chromoendoscopy, dysplasia was detected in 19.6% and 12% undergoing dye versus white light screening respectively, with trend towards favoring dye-sparing chromoendoscopy with p-value that was very close of reaching significance at 0.06. In non-randomized trials, dye-sparing was more effective than white light in identifying dysplasia, with p-value of less than 0.01 and risk ratio of 2.62. When assessing high-grade dysplasia specifically, there was no difference between white light and a dye-sparing in both randomized trials and non-randomized trial data. The total procedure time with dye-sparing was on average 6 minutes longer than white light. Therefore, in conclusion, non-randomized trial data suggest a robust benefit of dye-sparing over white light in display detection, while randomized control study data suggest only a small potential benefit. Next is looking at vedolizumab prevention. Looking at vedolizumab to prevent post-op recurrence in Crohn's disease. This is the results of the Reprevio trial. The aim of the study was to investigate the preventive effect of vedolizumab, an anti-integrin antibody, on post-op recurrence of Crohn's disease after patients have undergone ileocolonic resection. Following surgery at 4 weeks, patients were randomized to IV vedolizumab or placebo. Patients and investigators were blinded treatment assignment. 26 weeks after patients underwent ileocoloscopy for assessments of Crohn's recurrence. The primary endpoint was endoscopic resection of Crohn's. Secondary endpoints were proportion of patients with endoscopic remission, I2A, endoscopic remission, I0, and clinical recurrence. 80 patients were randomized. Patients in the treatment group had 78% risk of having a better root cause score than controls for assessment of high versus low risk recurrence. 70% of patients who received vedolizumab had I0-2A versus 38% of placebo, yielding an absolute difference of 39% in favor of vedolizumab. Endoscopic remission was observed in 42% for vedolizumab versus only 3% in placebo. Clinical recurrence occurred in 9 patients in vedolizumab versus 8 patients in placebo. Treatment with vedolizumab started immediately after ileocolonic resection and was highly effective in the prevention of post-op recurrence of Crohn's disease. Next is a liver study looking at diagnostic paracentesis within 1 day of admission, looking at its association with reduced mortality and shorter length of stay in hospitalized patients with cirrhosis and ascites. This was a systematic review and meta-analysis. Diagnostic paracentesis is recommended by society guidelines for all hospitalized patients with cirrhosis and ascites, regardless of reason for admission. 25% of patients with ascites develop SBP. Recent literature has reported that delayed paracentesis associated with a 2.7 increased risk of mortality, with a 3.3% increase in mortality for every hour delayed. Currently, no specific timeframe recommendations exist for inpatient paracentesis. The authors conducted a systematic review and meta-analysis to evaluate outcomes among patients receiving paracentesis within 12, 24, and more than 24 hours. This was a systematic review of literature using multiple databases, and the outcome of interest was mortality and length of hospital stay due to early versus delayed paracentesis in patients with cirrhosis and ascites. The authors included 8 retrospective studies, which totaled 116,174 patients. Included in the final meta-analysis, pooled risk of in-hospital mortality was significantly lower in patients who underwent early compared to delayed paracentesis. On subgroup analysis, there was a trend towards reduced mortality in patients who underwent paracentesis within 12 hours compared to within 1 day, although this difference was not statistically significant. The risk of in-hospital mortality was significantly lower in patients who underwent diagnostic paracentesis compared with no paracentesis. And the length of hospital stay was also shorter by 5 days in patients who went early compared to delayed paracentesis. In conclusion, early diagnostic paracentesis is associated with significantly reduced mortality and shorter length of stay in hospitalized patients with cirrhosis and ascites, and paracentesis should be performed at least within 1 day of admission, with efforts to perform the procedure within 12 hours if possible. So this concludes our GI Journal Club for June. Our next Journal Club will be the first Wednesday of July, which is July 5th, 2023. Thank you so much for joining us this morning. I hope you have a wonderful day, week, and month, and I look forward to seeing everyone in July. Thank you so much. Please have a wonderful, blessed day. Goodbye.